Welcome everybody. Can you hear me okay? Back row, can you hear me okay? Awesome, thank you. I'm Katie Ryan Anderson. I'm our marketing manager at JRMC. I've had the great privilege of working at JRMC for 6 years now, and offering this education has been one of the greatest blessings because I know, as you can see, folks are suffering and not living their greatest quality of life. And so this is a great way that JRMC can offer information to individuals so they can make the best choices for themselves and their family. And so before I introduce Dr. McAdoo, I just had a quick JRMC update to share with you. And you can't hear? You got to talk like right up to it. So be ready, Dr. McAdoo. Okay, we'll get a little friendly with the microphone. So JRMC, our mission at JRMC is to exceed expectations and be the difference in the lives of those we serve. And our vision is to be the best rural hospital in the country for providers to practice, patients to receive care, and employees to work. And that's really special that in a vision statement that we would even include employees. So if anyone's considering full or part-time work, I hope they consider us at JRMC. So just a few updates to share with you. We'll start with wins. And there's plenty of seats, ladies. So if anybody wants to come to the front row, you're sure welcome. In just this past year, JRMC received awards as a top 20 critical access hospital in the country. And if you've been to the classes before, you might know how many critical access hospitals are in the country. Does anyone want to take a guess? Who said 200? You're super wrong. Try again. 1,300. So we've been a top 20 for 3 consecutive years out of 1,300 nationwide. Thank you. And that's credit to our hardworking teams to ensure that our patients receive the best care, and you deserve the best care. And then in addition, we have consistently received awards as a best place to work, both in the nation and in the region. So nationwide, out of all healthcare organizations, and not just hospitals, but nursing homes, software companies, insurance companies, that we've received the Best Place to Work award 5 times since 2017. And then Prairie Business Magazine has named us the top 50 best place to work in the upper Midwest, so North Dakota, South Dakota, Minnesota. I've lost track of how many times, but multiple times in the last 5 years. Our teams get to have a lot of fun. That's us at the Carrington Parade. And then some of you might remember when we moved to our new location 11 years ago. A few of you, yes. So you might remember that back then we had 2 specialty care providers. So we had Dr. Harris in podiatry, and back then Dr. Dean in orthopedics. He had just joined the JRMC team. And today we have more than 18 full-time JRMC providers that live and work and raise their families in this community. So that's a really big deal. And then in addition, back then we did about 1,000 surgical procedures in a given year, and now we do more than 3,000 surgical procedures in a year. And back then they're called locums in the ER, which meant that they were contract workers. They'd come from wherever across the country and fill in for 13 weeks or whatever amount of time. And they were awesome providers. They did great work. However, now that we have 5 full-time providers, it just ensures the continuity of care, both for our patients and then within the medical community. Because as you know, if you come to our emergency department, you might have somewhere else to go for follow-up care, whether it's your primary care provider or a specialist for that broken bone or whatever it may be. So that's been a real win and a real gift to JRMC and to this community. This is all the specialty care we provide. And again, we're a critical access rural hospital in Jamestown. So to be able to offer all of this specialty care is a big win. And then these are some of our newest providers. We have our OB/GYN team, who you'll meet today. Dr. Emily Strongquist is not here today, but she's one of our amazing OB/GYNs, and she actually joined us 1 year ago this month. So we're really excited to have all these folks here today. And then Dr. Williams, the second from what side am I on? Second from that side. He's our new urologist, and he's originally from Cavalier, North Dakota. So a urologist handles kidneys and below the belt care, so bladders, prostates, kidneys, those sort of things. He's a real blessing for us to have here at JRMC. And then Dr. C.P. Barton III, he's our new ear, nose, and throat specialist. And he's not from North Dakota. He has a very sweet Southern accent. He grew up in Alabama and then has a history with the military. So he's worked all over the country, in fact, all over the world. And yet when it was time for him to choose a place to work permanently, he chose, of all places, Jamestown, North Dakota. So we're really fortunate to have him here. And with that, Dr. McAdoo is, again, one of our newest OBGYNs. He has decades of experience in women's care. He joined JRMC about 2 years ago. He's a Williston native, and we're so glad to have him here. So if you will join me in welcoming Dr. McAdoo.
Mackenzie's in the back there. She's the nurse practitioner that works with our team, and she had said that the back row needed the volume up a little bit. Maybe my voice will, deeper voice will help that a little bit. Can you hear her back there? Okay. I'll try to, if you can't, raise a hand or something, and I'll try to adjust the microphone or something, and so you can hear that a touch better, or try to be directing my voice towards the microphone well here. But thank you all for coming. It's actually beautiful weather for February in Jamestown, I think. But I'm thrilled to be here. I'm thrilled to be practicing here. It's a great hospital to practice at. We have excellent nursing care, excellent anesthesia care. If I didn't feel like I could do my job as well as I could anywhere in the country, I wouldn't be here. We were blessed with excellent physical therapy that they don't have in towns twice this size. One of them will be speaking with you a little bit here, and you'll be able to ask questions of Sherry here. We have just a great hospital to practice and to be cared for at here in Jamestown. So for pelvic floor care, what is healthy? And that has changed a lot since I started practicing over 20 years ago. The times to seek care now are anytime you have a concern, essentially. We're starting pelvic floor physical therapy on ladies that are pregnant now, and it's encouraged in every pregnancy and for everybody's postpartum care. It's just part of the routine care, not just for people that feel like they're having problems. We're using a lot more preventative care in pelvic floor, just like we are in other areas, just like we do to try to prevent heart disease instead of just treating heart attacks, just like they do for stroke prevention or osteoporosis or things like that. So signs of concern and when you should consider seeking care would be things like leaking urine or sudden urgency to urinate, frequency of urination, using the restroom more than an hourly basis, or if it's affecting your life, that'd be a great time to even if it's not hourly, but it's still affecting your life. Difficulty emptying the bladder, tissue prolapsing, pelvic pain, or painful intercourse are all really good signs that it's time to seek care. Usually there are things that we can do short of surgery. Most things, I would say we probably do only surgery on 20% of patients that present with any one of these symptoms. So it's not very common that surgery is even required to help with these symptoms. So what can you do at home? Well, there's things like strengthening the core, managing fluids, managing weight. Obesity is a risk factor for prolapse. It's a risk factor for leaking urine. A lot of times weight loss will improve those symptoms significantly. Limiting alcohol. Alcohol is a bladder irritant. There are other bladder irritants that make the bladder feel like you have to urinate more frequently, and those are things like citrus fruits and beverages, caffeine is a big one, and then alcohol. So those are all things that can be done to help improve symptoms. Quitting smoking can help. Smoking decreases the blood supply to the vaginal tissue, just like it does to other areas of the body, and increases risks of prolapse. And so that's another modifying risk factor that can be done at home prior to seeking care. So the options available to treat symptoms of leakage or prolapse are essentially the biggest options we have, or the most common options are, there's some of them can be helped with medication, medications for bladder frequency, medications for to help improve the tissue in the vaginal area to help prevent prolapse. There's surgical options. There's surgical options for leaking urine. There's surgical options for prolapse. There's pessaries for prolapse that can be used. They're kind of like a diaphragm type of device. There's multiple different sizes and types of pessaries that can be used for comfort. Doesn't limit. Some of them can be used even when ladies are still sexually active. Some of them can be removed by patients at home. Some of them need to be removed and followed in the clinic. And then pelvic floor therapy is another option, and that's typically the cornerstone to a lot of this. Most patients will benefit from pelvic floor therapy. We have excellent specialized pelvic floor therapy, which we're really lucky to have. Sherry's with us today. It's more than just Kegel exercises. I think that's what people heard for so many years, that go do Kegels, symptoms will improve. Unfortunately, that's just not the case. Kegel exercises can cause more harm than they can help at times. Sometimes they increase the bladder spasms, and they need to be done in an appropriate way. And Sherry and her team can help patients learn how to approach that correctly. And so you're can be doing more help to yourself than you can be harming yourself. So we'll have some very specific, looks like we have a lot of questions on some of the pelvic floor therapy and stuff, and we'll get into that more. But Sherry, do you have any couple words you'd like to say, or no? You're good. We'll get into questions here and stuff very, very shortly. The talk itself is pretty short. What else should you know about women's health? Well, there's more than we can cover in this time period, of course, but you know, there's ladies that have painful or abnormal menstruation. There's lots of options for treatment of that anymore. Most patients don't need to be operated on. Abnormal pap smears, of course, need to be followed up on. Urinary incontinence, hot flashes, painful intercourse are all things that we help manage. So I have, you may not believe this, that I'm old enough to need reading glasses, but I have a whole bunch of questions that were submitted already, so I'll get to those. And if you have a question specifically on one of these things, raise your hand and I can help answer that better. And then Sherry will maybe look at some of these that we don't, that I don't initially have on this sheet that were asked before the talk today. So one of the first things was interested in as much info as menopause as possible. There's some challenges with that question. Of course, there's a lot of challenges in menopause. The problem is it's so in all of medicine anymore is so individualized. I mean, for some patients, what menopause means or what symptoms that means, what they should be doing in menopause for their healthcare is so much different than other patients. And it's such an individualized treatment plan or history that it's very challenging to just state one thing for menopause. Some patients are good candidates for taking hormone replacement therapy when they go through menopause, and some patients are not. There was a lot of concern after 2001 when the Women's Health Initiative study came out and said that there was increased risk of hormones with breast cancer. We've got a lot of good data that don't show that anymore. And so there's some really good information, but it's very patient specific. It's no longer, I think it used to be when, kind of right when I got out and practiced 20 years ago, we would talk about that most patients needed to be on hormone replacement therapy. And then we went to, after the 2001 article, we went to most patients shouldn't be on hormone replacement therapy. And the problem with that is it's not very individualized. It's a very, very individualized care program, and it may vary hugely in siblings that are 3 years apart in menopause or something. And so it's just very individualized anymore. So it's hard to kind of go into all of menopause and what somebody would need treatment for or something like that. How normal is bleeding during intercourse, mid-cycle, and perimenopause? It's extremely common to have irregular bleeding in the perimenopause. So perimenopause is defined as the time around the last period. The last period, our menopause, is by definition not having had a period in 1 year. Perimenopause is the time around that. And perimenopause can start for some ladies at 42 and last for 8 years, and some ladies at 51 and lasts for 6 months or something. It's not always the same, but having bleeding during intercourse mid-cycle may be very normal, but it is something, any abnormal bleeding is something to run by your provider and discuss whether it's a concern or not. There are patients that have very high risk for cancers. There are patients that should have a pap smear. So that's a great question to ask. It's very common and probably does not mean anything serious, but it is a good time because it is out of the ordinary. Doesn't mean it's not frequent or common, but it's out of the ordinary and should be discussed with a provider. Vaginal dryness. There was a lot of questions about speaking to vaginal dryness. After we quit using hormones quite as much and people got nervous about hormones, we started having a lot more patients with vaginal dryness and problems with discomfort with intercourse then due to the vaginal dryness, more prolapse because of lack of estrogen to that tissue. Vaginal dryness is likely to happen postmenopausally. The vaginal tissue without estrogen is only a cell or two, 1 or 2 cell layers thick. And with estrogen, it's about 8 to 10 cell layers thick. And that makes a big difference in vaginal dryness. It makes a big difference in the suppleness and the health of the vaginal tissue. And so vaginal dryness is, I almost expect patients 55 plus to have that as part of their symptoms. Typical treatments, the best treatment for vaginal dryness is using some vaginal estrogen, which is a prescription and needs to, a patient would first need to be evaluated for that prescription. But that vaginal estrogen is kind of like using a steroid cream on a rash. It's not absorbed. If we use the appropriate dosing, it's not absorbed and doesn't cause a change in blood estrogen levels, and so can be safely used in most anybody. We have patients undergoing breast cancer therapy that were currently okayed by their oncologist to use it. So most patients would qualify to be able to use that. Other methods for vaginal dryness are, there's lots of good products on the market now for vaginal dryness. There's just like other tissue, we use like a hyaluronic acid for eczema or skin changes. The same types of medication are out there for vaginal dryness. There's lubricants, and then there's a combination of lubricants for intercourse as well as vaginal moisturizers, and they're really good products, and we're lucky to have those now. And I think, that's only been probably in the last 5 to 10 years that we've seen such a proliferation of companies making products for that, and they're healthy to use. And typically the vaginal moisturizers need to be used regularly, just like skin moisturizers need to be used regularly to keep from having dry skin. It's not something you can just use once in a while, but they work very well. And there's lots of good ones out there now. And those are over the counter. Why am I still having hot flashes after 10 years? Good question. Some people don't have very many hot flashes. Some have them for years. And not all hot flashes are caused by menopause or lack of hormones during menopause. Some hot flashes are caused by medications. Some are caused by ladies that are heavier, or men for that matter, that the fat tissue will metabolize or create some kind of estrogen components, which makes for some variability in estrogen levels, which then causes the hot flashes. So obesity has a role in hot flashes. It's the same reason why obesity is a risk factor for breast cancer, because there's a change in hormones, an increase in that estrogen. One of the reasons why it's an increased risk. Over-the-counter supplements. What do they actually do? Well, one of the challenging aspects that we have with over-the-counter supplements is we aren't sure. Anything that we prescribe as physicians or providers, advanced practitioners, physical therapists, have gone through a FDA approval process where those medications have been in trials, and they've assessed what risks there are, what benefits there are, and assessed whether those are safe. And because of most over-the-counter supplements haven't gone through that, it's very challenging for me to even address that. Some of them may work, some of them may cause an increased risk. We have to remember, just because they're over-the-counter does not mean they're better, though, or less risky for you. Okay, incontinence, kind of there'll be a number of questions on it, or were a number of questions already. I have questions about patients that have had surgery, hemorrhoidectomy type stuff, and still having problems. Actually, bowel incontinence, I think, is probably like something somewhere around a 10% risk in patients that have had previous tears during childbirth. And so it's a lot more common. People don't like to talk about it. They're worried about talking about it. They think they're the only patient. It's an embarrassing subject. Usually surgery is not indicated for bowel incontinence. Usually surgery would be the last step. And typically the surgery that would be done for bowel incontinence should be done by an extremely specialized surgeon for bowel. We don't happen to have that. It's one of the things we wouldn't have here. We do a lot of the workup, help get people ready. But when you have that sort of problem, it's probably best managed by the most experienced surgeon you can find. But there are a lot of things to do short of surgery. You know, physical therapy helps a lot. These are patients that respond well to physical therapy. Dietary changes can help a lot. So adding fiber to the diet, changing that can make big differences. So there's a lot of new data on dietary changes to help the gut flora, your bacteria in your colon and bowel and stuff. And there's a lot of, and even for weight loss doing that. And so there's a lot of good new stuff we've got going on there. Bladder doesn't empty completely, lots of leakage. What are the options? The first thing to do in that situation is to do an exam. Sometimes people are leaking because the bladder is actually overfilled, and we need to assess if the bladder is overfilled, why is it overfilled? Is it something that caused a problem in the nerves to create the bladder not functioning properly? Is it just kind of chronic? The nurses and teachers not using the restroom frequently enough, and the bladder just gets kind of stretched. That happens too, and those are all things that can be helped significantly, and usually Sherry and physical therapy can help a lot with that type of problem. So when the bladder doesn't empty completely and there's lots of leakage, it could be that. Sometimes it's prolapse, so an exam will help tell us if it's prolapse. The bladder, when it's prolapsed, kind of makes an angle that doesn't allow the urine to drain well, and sometimes that prolapse needs to be helped with either a pessary type of device or surgery to help the bladder drain well, and that helps the leakage as well. There's a lot of people that have had urinary leakage procedures or prolapse procedures that now it didn't help. They had it years ago. With urinary leakage, it's really, really, really important to be evaluated first, and before doing a leakage surgery, it's important to make patients aware of what their chances of success are. There have been a lot of procedures done in people that shouldn't have been done because it wasn't going to be successful. And so when we choose our procedures well as physicians, when we have a lot of experience doing this, I've done urinary leakage surgery my whole practice, and the current procedure I use is pretty much the one I've been doing since the year 2001, when I started training other physicians, including urologists, how to do this incontinence procedure. So it's really important to have done a lot of the surgery. It's important to help choose patients wisely, do a very extensive workup. And so sometimes when that was not done, people will have slings that didn't help with leakage. Usually when that's done well, about 80 to 90% will be improved significantly of their leakage with the sling procedure. And then if you accompany that with also doing pelvic floor therapy, it's improved even more. We don't typically want to do those surgeries without including pelvic floor therapy. It's kind of like joint surgery, and they usually have you do some physical therapy around joint surgery because a combination of the two will help symptoms the most. But sometimes when a sling has been done years ago, it can create problems then when there's prolapse and the bladder's not emptying well. And so the most important thing would be to be evaluated, and so we can determine if it's the sling that failed, if it's a new problem, if the slings don't typically fail. I happen to bring one with me just because I thought there may be some questions. And actually only about half of this is left in the body, and none of the plastic stuff is left, nor is the blue left in the body. Those are all ways to get the sling into the body. We only keep about this much of it in the body. It goes underneath the urethra. There's about an incision about this size underneath the urethra in the vaginal tissue. It does last forever, which is a good thing because typically the leakage is helped forever. That's not a guarantee, but it's hard to study things past 10 years because patients get lost to follow-up. They may die of other causes, they may move, they may quit answering all the questions they get asked over and over in a study. And so we only have data out 5 to 10 years on the leakage, but it doesn't tend to wane with time unless body shapes wane with time. If a person's weight changes dramatically after surgery with sling, their leakage can change dramatically too. That would probably be the biggest factor, or their health, or their smoking history, or prolapse maybe. Just like anything else for our health, the better we take care of our health, the less problems we have. But that's a sling. It's rare. I don't know that I've had to take a sling out in 10 years of practice. And I've done hundreds of them. So it's very rare to need those taken out. That it happens, but it's not very common to need those taken out. There was a lot of concern, and there's ads like if you've ever had a sling or mesh put in some of if anybody else has insomnia like I can have at times, they've seen the ads on TV and late night TV. They really aren't related to the slings we currently use for leakage. What happened was the slings we were using for leakage were so effective that companies started making slings for leakage because they could see this is a problem that millions of ladies a year have leakage problems. And so these companies went, gosh, Johnson & Johnson, who happens to make the sling that I use, is making so much money on this. We want part of that. And they started making slings, but they didn't go through proper FDA approval. They just said, ours are just like theirs and they're just as good. They didn't get their physicians trained as well to put these in. And they had problems. And so what the FDA said, they didn't recall ones that were put in patients, but they said, hey, if you want to market these products, you have to go through FDA approval. You have to have these surgeons trained in each of these procedures. And so a lot of the companies went, it's not worth our time and money to do that. But some of the big companies kept doing what they were doing, and they kept doing it well. And so they aren't fly-by-night companies typically anymore that are in and out of business. They're companies like Johnson & Johnson, who's one of the biggest corporations in the world. And so we have a lot less problems with them now. And that's because when they're done right. They're done with good material. Doesn't mean things can't happen, but it's a lot less likely to. Great question. It actually isn't attached, and it's like a weave of, if any of you, I don't do any sewing except on bodies, but it's a weave of suture basically. I can leave it up here and afterwards people can take a look at it, but essentially what it does, it's a kind of a weave of suture, and the tissue grows through it to stabilize it. So the first couple months especially, we have to have patients really careful about putting too much stress on it so it moves before the tissue can grow through it, but there's a bunch of little holes in it. And then it also has, if anybody's ever used ski skins to be able to kind of walk up a gentle slope in skis, or understands at least that principle, there's the reason it has plastic around it is I can't put it in a body because it has a anti-slip aspect the way the weave is, and won't allow it to move very easily unless there's plastic around it. So to get it in, I have to use the plastic to get it in, and then I take the plastic out. And so it's got kind of that ski skin won't slip in there unless there's a lot of pressure on it, so we have people not lift over 10, 15 pounds for 6 weeks, and we have them not do core activity for 6 weeks, and no shoveling snow and all that jazz. The ranch ladies have probably the biggest problem because they're just so used to lifting those feeding buckets and doing too much. But it has kind of both those things. So the anti-slip, and then it has a bunch of holes in that allow the tissue to heal in. But a very good question. So urinary tract infections, experiencing low estrogen that cause urinary tract infections. What can we do about it? What food should we eat? What should we not eat? How does fiber play a role? How does it impact it? How does fiber impact medications, constipation, and diarrhea? Well, my nurse practitioner, Mackenzie, has seen me talk about fiber all the time, all day. Fiber plays a huge role in our gut health. It decreases our lifetime risk of developing colon cancer. It improves the consistency of the stool, decreases the risk of prolapse. There's a new study out that suggests it probably plays a role in prevention of Alzheimer's. There's some gut bacteria and some proteins that are released when you don't have adequate fiber, and fiber may have a role in that as well. And so fiber is very beneficial for bowel health as far as constipation, both constipation and diarrhea. It kind of keeps the stool at a medium consistency. I was a big convert when the general surgeons who deal with colon cancer told me how important they thought it was. Is I have some general surgeon friends that go and they backpack and hunt in kind of the mountainous regions, specifically in Wyoming. And everything they hunt with, they carry on their back, or everything they're cooking with, they carry on their back to get to these places. So weight matters, and they take fiber with them when they go and carry that on their back. That's how important they feel it is. They start their teenage kids on fiber. Extremely important. It probably doesn't have a role in prevention of urinary tract infections, but it definitely has a role in bowel health, decreasing risk of colon cancer, and in most patients doesn't carry any risks. Some fibers in some people will cause more gas production. It changes kind of the gut flora, which in some ways is good, but sometimes you need to find the one that's right for you. So big proponent of fiber. Urinary tract infections are more frequent in menopausal ladies. They can be helped with estrogen use. It changes. We talked about how it changes the texture and the strength of the vaginal tissue. It makes prolapse less common. It also changes. There's receptors of estrogen in the urethra, which is the drainage tube from the bladder into the top of the vaginal area. And estrogen can help decrease your risks of urinary tract infections. Sometimes the feeling of a urinary tract infection is not a urinary tract infection, however. Sometimes that's just the reason that people often know they have a urinary tract infection, or they have to go to the bathroom frequently. And sometimes that's just a bladder spasm. And so what we do is we check a urine. If the urine is normal and patients are having spasms, we talk about those things that cause spasms, like I already talked about: alcohol, caffeine, citrus fruits and beverages. And then we just like if it was another, the bladder has a muscle all the way around it. And when muscles spasm, it can be from injury, it can be from infection. To help stop the muscles from spasming, just like if it was a muscle in the arm and the arm was spasming and creating problems with the arm moving, physical therapy helps out a lot. The physical therapist can help work and help retrain those muscles around that bladder and decrease that frequency of urination, decrease leakage, decrease painful intercourse, because that's often muscles around the vaginal area spasming and creating more problems. Anything else I'm gonna add? We'll get into some other questions here too, but once again, reading glasses here, apologies. Okay, we're there. Pelvic floor therapy. Does the hospital offer biofeedback using machines and doing certain therapy treatments?
All right, I have a really high-pitched voice, so let me know in the back if you can hear me. I'm getting some head nods. Okay, I do not have the deep voice that Dr. McAdoo does. Okay, so the biofeedback, yes, we do offer biofeedback. It is a type of internal unit or external in a way. We are monitoring the activity of the pelvic floor muscles that Dr. McAdoo was talking about. A lot of us maybe don't even know these are there, or yet alone how to activate these muscles correctly. So this gives us a visual or auditory feedback of if those muscles are doing anything. So that can be really helpful if you're like, I have no idea if I'm doing this. Like, what do you want me to do? This gives a visual feedback of the muscles, if they're activating, if they're not activating, and it can be very helpful in retraining our brain and those muscles to do what they're supposed to do. So that is something that we're very fortunate to have at the hospital. It's very beneficial in pelvic floor therapy. It's not always necessary. We can often do therapy without needing it, but it is an option. We have.
Nor does a patient have to do it if they're not comfortable with it.
Yep.
It's just a way to help them gauge whether they're doing it well and to give kind of the feedback to whether it's helping.
Exactly. So it's, if I ask someone to do a bicep curl, it's easy to see if their arm is moving. Okay, yes, you're doing it. Pelvic floor, you can't visually see that happening from the outside. So that's a little bit tougher, but there's definitely things we can do without doing anything internal to still help you retrain and learn how to activate those muscles. It's just another tool in our toolbox. Essentially, that's one thing in therapy we love to build is tools in our toolbox. In addition, there's another option such as vaginal electrical stimulation. If those muscles are really having a hard time firing, sometimes we add a little bit of stimulation to them to kind of get them more excitable and get them firing easier, just like we may do it to the quad after a total knee that's having a hard time returning back to function. So those are just a couple options of modalities, I guess we call them in the therapy world, or tools in the toolbox that we can do as far as that goes. Doing certain therapy treatments, I'm not quite sure. I'll do my best to answer that. Oftentimes, a physical therapy treatment will include some sort of biofeedback, whether it is with a device or externally with our hands, just palpating, feeling for core muscles, or reactivating glutes, adductors, different muscles globally. Can we turn those off and still do a pelvic floor contraction? Manual therapy, we like to do work on the surrounding tissue, not just the vaginal canal as well. We may have overactive back muscles, abdominal muscles, glutes, hip muscles that are all affecting what's happening. And we often see that patients with pelvic floor dysfunction have a correlated low back pain or hip pain. And so we're not just treating the pelvic floor, we're treating the whole individual in those sessions as well. Exercise is going to almost always be a part of it. It may be added in later. It depends if you have a pelvic floor that is overactive or you have muscles that are overactive and just working overtime to start with. It may be just a lot of relaxation and down training. So like Dr. McAdoo said, Kegels are not always the right answer. In an overactive pelvic floor, Kegels can make things worse. So we don't want to do strengthening exercises if everything's overactive. We want to work on relaxation, stretching, down training, getting everything in a normal resting state before we add exercise. So sometimes your therapy sessions will look like, oh, I'm in a meditation room and just trying to get things calmed down. So it varies from person to person. It's very individualized in what's going on.
But for about 60 to 70% of ladies that leak with urge, like sudden urge symptoms and leak, about 60 to 70% of them will be improved with physical therapy.
And a lot of that's behavioral retraining.
Correct. Diet changes, behavior retraining. Yeah.
And
it does work.
It does. And so sometimes our sessions is more just education and working on what our day should look like for a healthy bladder. And what a healthy diet is a huge part. And sometimes that's a hard thing to hear, that you can't have my 5 cups of coffee a day because it's causing problems. So that, it just varies. But yes, if it's an urgency related thing, we often see that it's not necessarily a strength issue. Sometimes it's a coordination issue. It's not contracting at the right time. But a lot of times we've trained our bladder into bad habits and then we just keep feeding into it. And then it just gets worse and worse. And some of this can even be stemmed from childhood, so don't feel that it's all your fault. I mean, we were brought up in an era of go to the bathroom because we're not stopping, you know. Are you sure you don't have to go? We're hitting the road. It's gonna be a couple hours. I'm not gonna stop. And so, you know, we kind of just do these just in cases. And those are a really bad habit to get into and a bad habit that we carry on because that's just how we grew up. So there's a lot of things, and that's a behavioral change for us to make to improve our bladder health.
Since there's one of the next questions on here is about insurance and costs and stuff. Do you want to just from pelvic floor therapy, some patients, I thought maybe you could hit that. I can hit it for other testing, but maybe you'd want to go through that, what you guys have to offer for that.
Absolutely. So as far as pelvic floor therapy and insurance, almost all insurances will cover pelvic floor therapy. We haven't run into any snafus with that. It does vary whether you need a doctor's referral though. Depending on your insurance, you may need to have a doctor's referral, and this could be from your primary care doctor, or it could be from a specialty doctor such as Dr. McAdoo or Dr. Stromquist, Dr. Williams. And oftentimes, if you are coming to therapy and you don't need that referral initially, if we see any concerns or signs in our evaluations, we will often mention that it would be a good idea to follow up with one of these, and we'll send a message down to them, say, hey, I just saw a patient, you know, this is what I noticed, here's what I'm thinking, or, you know, I think it would be really good for them to follow up with you, let me know what your findings are, what your thoughts are. So we work really hand in hand with the clinic, but it doesn't mean you can't see your primary care provider and get a referral as well either. Blue Cross Blue Shield, you know, private health insurance, they don't require referrals, but Medicare, Medicaid, those other insurances will require referrals. So sometimes it's just reaching out to us. We can help you usually with those questions, and we do free screenings as well. And in those screenings, we can go over.
Was that like a 30-minute free screening?
Yeah, 30 minutes, free screen. You can be seen by a physical therapist. We can address questions, concerns, and kind of see if it's an appropriate option for you. Or maybe you should start with seeing Dr. McAdoo first and then go from there. So.
Thank you. It's physical therapy has become such a mainstay that insurance has recognized that as well. That's why they're allowing it to be used in a lot of insurances without a referral first. That's why they're covering it in most cases. Sometimes that's limited by how many, you know, how many appointments. Typically with and I'll speak only be not quite as much knowledge about this as Sherry, but this isn't the type of physical therapy where you're going to go Monday, Wednesday, Friday. This is not like cardiac physical therapy type of thing. You're talking about a visit, maybe a visit 2 to 4, 6 weeks later for reassessment. You know, usually 3 to 5 visits would be kind of normal, something like that. So it isn't quite that extent of 3 times a week, you know, for the next 6 months type of physical therapy. So patients that live out of town that may worry about starting physical therapy because it requires so many visits, it really doesn't have to require that many visits. Sometimes it ends up requiring more visits, but typically it isn't that kind of frequency. Is that correct?
That's a soft voice. Yes, I would say most often, depending on what we're seeing you for, we may see you once a week for a couple weeks just in the beginning to make sure everything is going correctly. Because if you are doing them incorrect, it's not going to help you. So waiting a month isn't going to be in your benefit. So this is always a conversation I have with my patients. What is feasible for you? Is that too frequent? Do we need to look at, you know, spreading it out? That's fine. But if it's a lot of behavioral changes and modifications, yeah, we need to give you time for that to happen. It's not going to change overnight, and seeing you once a week isn't going to change that. It's going to be something that takes time. It's a behavior. But yeah, as far as if it's exercises, strengthening. If you're having a hard time that first visit, we likely will bring you in again, make sure everything's going good before we have you work on it for a while. But it's not usually a twice a week for 6 to 8 weeks like you would have after a total knee or a total hip. This is usually a lot different looking as far as frequency.
Thank you. Couple of the other questions revolve around painful intercourse, sometimes after hysterectomy, around menopause. Typically, there's a lot of options. One of them is physical therapy. Sometimes those muscles, that the vaginal area is surrounded by muscles, and those muscles can engage just like other muscles can, and spasm and cause pain. And physical therapies can be a big component of improving that. Sometimes the pain is due to dryness. I already kind of talked about estrogen's effect on that. So there's lots of options, but typically somebody would need to be first examined and to determine what the best option for them would be. Preventing UTIs after 60 with intercourse, very similar to preventing UTIs prior to 60. Voiding after intercourse can help. Sometimes intercourse, whether it's a honeymoon cystitis, which happens, bladder infections with honeymoons, or whether it's a 65-year-old with honeymoon cystitis, there gets to be some bacteria in the urethra, which empties the urine into the top of the vagina, and intercourse can push some of that bacteria up near there, and if you void immediately following intercourse, that helps wash out that bacteria. So staying hydrated can help. Voiding immediately afterwards. Estrogen to the tissue, I've kind of already mentioned that. Vaginal estrogen can help that. Let's see, how to work out insurance with all these tests. So anymore, insurance is the people that deal with insurance, it's can sometimes be the most challenging part. This, however, is not like surgery for like plastic surgery or something like that. It is covered by insurance. It's subject to insurance deductibles, but most of this is all covered by insurances. Pelvic floor therapy is usually covered. The office visits are usually covered. The surgery is usually covered. And if it's not, we let people know that ahead of time. I don't know that I've seen that in 10 years, the surgery or those things not being covered, as long as the insurance is in full effect. Unfortunately, because of the cost of everything these days, people have high deductibles, and that is always challenging, of course. Yeah. Oh yeah, yeah. So I kind of spoke to it as far to costs and stuff as far as leakage, prolapse, pelvic floor therapy. But there's a lot of people that can have trouble just getting their general care, pap smear, birth control, those type of things. And thankfully in town, we have great resources for that as well. Central Valley can help get signed up with the resources that are available. There's great donations in this town to help some of those costs out. We run a program through the hospital for people that don't have insurance coverage, or can't, even if they have insurance coverage, have high deductibles. Did you want to?
Jan from Central Valley is the subject matter expert. Do you mind saying a couple words, Jan?
Yeah, our women's things program.
Oh, there, I was looking. Thank you so much. Thanks for all your hard work. A few more questions that came up today. How does obesity affect pelvic floor? Obesity puts a lot of more pressure on the pelvic floor, just like it puts pressure on joints, just like it puts pressure on the heart having to pump through more vessel area type of stuff. Obesity affects the pelvic floor. It increases the risk of prolapse and leakage. Unfortunately, it's not just as simple as we all know. Just diet and exercise don't often work. I mean, obesity is a challenging thing. It's not usually it's a complex thing where it's very challenging to lose weight. And so I think we're getting to a place in medicine where we're going to have there's a lot of new medical options available now. We're having a lot more insight into what things affect weight, and I think it's going to be, it's just like everything else. It's individualized. What's right for some people may not be right for everybody. Just picking up the newest fad diet book is probably not right for everybody. It may be right for some people, but it definitely affects it affects strength. It affects ability to know if you're doing the right, just like it's hard to tell if a muscle is being exercised appropriately, if there's too much fat around it and it's a bicep muscle, it can be more challenging to evaluate the pelvic floor muscles in physical therapy as well. So it does affect that, and it puts more pressure on that tissue. How can I stop my bladder from waking me at night? Really good question. I mean, I think, not just for ladies, men and women, as they age, can start having more of this. Some of the things that affect this is if somebody's getting up a lot at night and they're going a lot when they get up, their bladder probably needed to be drained. And part of that is when we spend the day on our feet or sitting or whatever, we end up, especially as we age, we end up holding on to a little bit of extra fluid during the day in our tissue. When we lay down, that fluid gets mobilized and processed through our kidneys, and that's why there's fluid in the bladder that needs to come out. It's because we mobilize that fluid. So doing things like for a couple of hours before going to bed, putting feet up on pillows on the couch or on the easy chair can help you mobilize that fluid before you go to bed. But if you're getting up a lot at night and going small amounts, that should be evaluated, and often physical therapy can help with that. If you're getting up a lot at night and going large amounts, that is one of the things you can do, is that fluid needs to come out. So to prevent somebody from getting rid of fluid that needs to come out is not always healthy, but there are ways to manage it, like decreasing the amount of fluid before going to bed. Alcohol before going to bed is not going to help that at all, or caffeine. They're diuretics. They're going to cause the body to release fluid and create more fluid that's going to need to come out. So those are things to help that out. Have problems with constipation. We talked about fiber recommendations prior to menopause, or in ladies, are 25 grams of fiber a day. An apple has a big apple has 5 grams of fiber. So most people can't get enough fiber in their diet to help get them the adequate amount of fiber. Men need 35 grams, so that's the recommendation. After menopause, that's 20 grams of fiber a day. That helps with constipation a lot. Exercise helps with constipation a lot. Sometimes constipation is because of poor pelvic floor. Sometimes it's engaging the pelvic floor wrongly. It's not lack of strength, it's engaging it wrongly. And so it's an inability to relax that pelvic floor. And sometimes, physical therapy can help. Sometimes constipation and lack of inability to empty it well. Sometimes people have that if they have the rectum is kind of pushing up into the vaginal area a little bit. Happens after childbirth, sometimes years after childbirth, sometimes months after childbirth, but that's called a rectocele. It's kind of a hernia of sorts, and sometimes ladies even need to splint to kind of push vaginally to help have a bowel movement, and that often needs to be helped with with a combination of pelvic floor therapy, pessary, or surgery. What do we do to lift things up? It's not plastic surgery in the essence of insurances or that type of thing, but it's kind of like a plastic surgery where we it's kind of a nip and tuck. We open the tissue up and push the tissue that's prolapsing and kind of tighten things up. Prolapse surgery has changed a lot in the last 5 years anyway. People that have failed prolapse surgery in the past may not have had that prolapse surgery done appropriately. They may not have had the hysterectomy done appropriately, and that doesn't mean the doctor at the time wasn't doing what they felt was the best thing. We just learned a lot more about it. We need to support the vaginal tissue differently. We need to get up to some ligaments that have good support, that were not injured during childbirth. And so our approach to it has changed, and so results have changed dramatically. It's less likely to recur now if it's approached in the new ways. Just like everything in medicine changes with time, that's one of the things that's changed with time. I'm not stating that somebody did inappropriate surgery at this time to not support things well or not try to support things well would be wrong in surgery, but we've learned a lot about that. So essentially, that's what we do. We rarely use mesh for a prolapse. We use that little sling for leakage, and that's the standard of care to be used for leakage surgery. But we rarely use mesh for prolapse, so that typically isn't used. Anybody nearby that can remove like a carbuncle? Sometimes there's little growths on the part of the urethra that you can see vaginally. And Dr. Williams, the urologist that works in the clinic, would be a great person to see for that type of thing. Sometimes it shouldn't be removed, but he would be the person to talk to about that. Let's see. Flatulence and incontinence. Often flatulence is our gut bacteria working on, everybody, colons produce gas. The bacteria in the colon is important for proper digestion. Changing the colon bacteria, I think, is something that we're going to see a lot more data on, research on, because it probably plays a role in weight and obesity, and as suggested earlier, possibly even a role in or appears to be with new data on Alzheimer's even. And so the bowel is going to produce gas. Now, not being able to control that it can be a challenge for somebody that's had previous childbirth where they've had tears, or even if they didn't have tears. That can be improved a couple of ways. One is through dietary measures. There are diets that will produce less gas, and then pelvic floor therapy can help improve the muscles to help decrease that as well. That usually wouldn't involve any surgery, though. Anybody else have any? I think I hit most of the questions that were asked prior to it, or ones we had presented today. I think they're great questions. They really, I think they're probably better than me just talking off the cuff about any of these subjects. So very good questions. Yes, ma'am.
Saying that even if there's like family history of breast cancer, it's okay to doing that?
Correct. Actually, estrogen alone in any person does not increase the risk of breast cancer. It may stimulate existing breast cancer, but it does not increase the risks. The studies only show an increased risk if you use it with progesterone. And you have to do that if you're giving a higher amount, because estrogen, if you're using too much estrogen, you can increase somebody's risk of cancer of the uterus. but there's a specific amount that we know, and when you use it vaginally with a cream, or there's little kinds of suppositories to use vaginally, that's not enough to change the estrogen level in the bloodstream to increase that risk. And so it can be used, and it's especially because we went away from using all the other, people are so concerned about using things orally or you know, some of the other estrogen components after those studies, that it's a very good option. Unfortunately, it's not always covered by insurance, but how we prescribe the estrogen cream in most people, even if it's not covered in insurance, some of the tubes that we prescribe last 6 months type of thing. And so nothing is, you know, just like the cost of eggs is whatever, $7 at times. I mean, I'm not saying it's cheap. It's real money. You know, we work hard to, you know, or we've worked hard to get that money. And it's hard to part with that when we've worked that hard. But it's not as bad as it may seem, I guess.
Way less than it.
Correct.
said.
Correct. Yep. Yeah, we have people use that cream. We have them use like a pea-sized amount on the end of a finger and put that in a couple of times a week. And so those expensive tubes of cream can last 6 to 9 months. Yeah, correct. Yes, in the back. So estrogen alone does not increase the risk of cancer. Estrogen, whether it's synthetic or a natural estrogen, if it raises the estrogen level up enough, it doesn't. There's some variations in how much is required, whether it's synthetic or not, to raise the estrogen level up, but if it raises it up enough, it will increase the risk of whatever estrogen has as far as a risk. It does not increase the risk of breast cancer, neither do though. It does increase the risk of stroke a little bit, not vaginal estrogen, but if you raise estrogen levels up enough in the bloodstream. But there are different types of estrogen that raise the risk of stroke more than others, and there's felt to be some that probably don't raise it. So I think there is some validity in what you're saying, but it's not if you get the estrogen by a bioavailable, non-prescribed, some of the estrogens that are compounding type of thing, that doesn't mean just because it's natural, it isn't causing the same risks as some of the prescribed FDA approved ones. So they may have the same risks. They just haven't gone through the trials to show us exactly what those risks are. So that's so some truth to that for sure. But just because it's natural doesn't mean it should be used without any concern. It should still be a discussion. Well, thank you all for coming out. Appreciate it. And, great.
So to close today, first, thanks everybody for being here and being shoulder to shoulder. I know it was a little bit tight on space. A couple upcoming events, and these are really special to JRMC. So Wednesday, March 15th, we're having our first ever Angels and Saints Acts of Love event at Pit Stop Sports. And all proceeds from this event benefit our Angels Fund. And the Angels Fund supports bereaved families who experience infant loss. So anyone who's experienced that knows how, of course, awful that is. And then what would be an insult to injury would be to get a medical bill in the mail. And so the Angels Fund covers all of those costs so that those families don't have to receive that bill in the mail, pay that bill. They take care of all of it. So that's March 15th. If you're interested, we'd love to have you. And then in March 16th, Dr. Michael T. Dean, one of our orthopedic surgeons, is offering a JRMC U just like this here at Track on total joint replacement. So if you're interested, you can sign up here, or of course, all of our classes are on jrmcindy.com/u. So if those are of interest, we sure welcome you. We're short on time, so I'm going to email all of you this survey, and I ask you to please complete it. It takes about 5 minutes, but it's how we know if we provided the information and education you were looking for. And so that's our opportunity to improve. So thank you in advance for filling that out after I email it to you. And then Marley. So if everyone wants to see Marley, we're going to pull for a couple raffle prizes. And then if you are a winner, see Marley and she will connect you with some goodies. Do you want to draw some names?
Sure.
Do you have time?
Sure.
Okay. Do you each want to draw 5 names? I've got 10 prizes back there.
Wow.
We knew it was going to be a big group.
Okay, here's 3.
Okay. I have Wanda. Wanda from 240 14th Ave Northeast. Wanda, are you still here? Awesome. Wanda's here. Okay. Diana Carlson. Yay. Got the blank. Okay.
I got blank too.
Okay. Julie winner. Woo! Margie Kern. Margie, are you here? Yay, Margie. Marcia. Marcia's right next to Diana. Okay. Sheila Nelson. And last one. Last one, Lisa Hoffman. Thanks everyone so much for coming.
Second.
Make sure. Good work.
Yeah. Thanks, Dr. McAdoo.
I think that was on the.
Well. These will talk again. Anything, if you think of anything that I can do, answer better.
Perfect amount of time, yeah. Questions were more, I think, as valuable as anything, probably the people.
I'm glad we started right at 11 and I'm glad I tried to zip through line because I'm so.
Yeah. Appreciate it.
So, yeah.
Hi. Yeah. Typically, yeah, it's metafiber, metamucil, that type of thing. It's the one, finding the one that, fits you, that you tolerate the best. Because some people tolerate one and don't tolerate another, but. Yeah, I mean, you put that like Benefiber, putting it in your coffee. I know I just talked about how coffee can increase like urinary symptoms and stuff, but decaf coffee, or whatever, but or mixing it into that coffee. Oh yeah, you can mix it in. It just doesn't end up changing the taste of my coffee enough to have me even know it's there really, so that's why for water, it's kind of like some people may tolerate drinking it, some others wouldn't, but if you mix it in with something, it typically doesn't really change it much.
Another question.
Yeah.
I just was been here, Dr. McAdoo.
Yeah.
What's the guy about starting with the pelvic floor thing?
Yeah.
I wonder
Yeah.
if he's still here. You had a couple questions for her?
Huh?
You had questions for her?
Yeah, I want that.
Some people, they're just like there's bad electrical signals going to the heart, they need a pacemaker for that. And there's bad electrical signals going to the bladder. Yeah, and those pacemakers, I put them in. I don't anymore because Dr. Williams does, and there's no reason for,
Yeah.
but they work really well in a lot of patients, and they're really low risk. There's really no downside. If it doesn't work, okay, you tried it. It's such a minimal kind of procedure, not even a surgery, and it may feel like it, but minimal and no risk hardly that it's changed people's lives. Changed people's lives, it tends to, the people that have had it for a lot of years, or they have like injections started it, like a bike accident, some people start this when they're 12. Stuff